Yes, it's an honor to be here. What I wanted to do, it's hard to do in 15 minutes, but kind of summarize this journey over the last 25 to 30 years. The take-home point is that the results of transplant are dependent upon the conditioning regimen and patient selection. There is, of course, a center effect, but it's the conditioning regimen and patient selection that is key. And at least in 5 diseases, I myself have the data to say that the majority of patients after transplant are more than 5 years free of their disease. And we've published that. And because there isn't enough time to go through those publications, you can refer to this website, stemcelljourney.com, and all the publications are there. And in fact, I can now say the majority keep remission beyond 10 years because I've been talking to those patients, getting more follow-up, and in fact, for relapsing remitting beyond 20 years. So, of course, this is multiple sclerosis, the typical Dawson's fingers, and it's the disease which I have the longest experience with. And this was our randomized trial published in Journal of American Medical Association 2019, and the regimen of cyclophosphamide ATG versus best available DMT pharmaceutical drug. And 60% of the patients, it was natalizumab. But in any event, here's the time to progression for the transplant arm versus disease-modifying therapy, and time to first relapse for disease-modifying therapy versus transplant arm. Highly significantly different. Those were the main endpoints. Again, this was very aggressive in terms of more than 2 relapses in the last year, despite having failed at least a first-line interferon or Copaxone. And recently, we just published in the Journal of Neurology in 2021 our results in 507 patients, all received non-myeloablative regimens, both on and off study. Of the 507 patients, 93 were secondary progressive MS, but I won't do secondary progressive. That's a neurodegenerative disorder. So we don't bring people for evaluation if they're secondary progressive. What happens is we're told they're relapsing remitting. We get here and we realize they're secondary progressive, but that it's kind of hard to say exactly when that occurred, but it appears to have occurred within the last 2 years, and we did them on a compassionate basis. They didn't do nearly as well in improvement in EDSS compared to 414 relapse remitting patients. Mortality rate was 0.2% of 507 patients for treatment. Here's the improvement in EDSS for these 93 secondary progressives, and I divided that into those who were active secondary progressive. That is, in the last year, they still had gadolinium enhancement on the MRI. There were 35 of them, and they did improve by about half a point. Those who did not, non-active secondary progressive, these are early secondary progressive, newly diagnosed, but the last year there was no activity, no enhancement on their MRI, and you can see there was no change in EDSS. You could argue it stabilized them, but they didn't get better, and I think you need a randomized trial to prove that. Whereas we've already shown in a randomized trial for relapsing remitting, especially with frequent relapses, that transplant is superior. And these are the 413 relapsing remitting patients broken down by their baseline EDSS. So of course you can have relapsing remitting and a very high EDSS. These are the means, and here are the number in each group for that EDSS cohort. And you can see they all improved. You just have to be careful if you're dealing with a high EDSS that it's absolutely relapsing remitting, but they definitely improved. This is Devick's disease, neuromyelitis optica spectrum disorder. What's different about this compared to MS? MS gets optic neuritis, but NMO really does get the optic chiasm right here. You can see demyelination, and then here you see atrophy. In MS, it's more often intraorbital, retroorbital, canicular, less often the optic chiasma, whereas in NMO, it's more often the optic chiasma. And the other is in NMO, you get these long, more than 3 vertebra in length demyelinating lesions. In MS, it's almost always less than 1 vertebra long, the demyelination, whereas in NMO, it's 3 or more, as you can see here, and it can occur in the vertebra. I mean, in the thoracic as well as cervical. It's actually more common in the thoracic than cervical in our group of patients. There's one other disease I'm aware that can give you these long demyelinating lesions, and that's neurosarcoid, and very, very rarely it's been reported in MS, but that's very rare. And here was our outcome: relapse-free survival after a regimen of plasmapheresis to diminish the alpha-4 antibody, Cytoxin ATG, and rituximab. We added the rituximab for the B-cell side of this. And again, it's published in Neurology 2019. You can pull it up from the website. Relapse-free, progression-free survival in EDSS, marked improvement in NRS. And this is different than the registry data, and I think it's because our mean EDSS was around 4, and the mean in the registry data was, I think, 6.5. And that's one of the reasons, and also the regimen. So it's patient selection and regimen. And in fact, we looked at the antibody right before. One was negative, the others were all positive for aquaporin 4. And those two that did not become negative relapsed at 2 years and 18 months. Everybody else negative at 6 months stayed in remission for 5 years. We did have 2 of them become positive again, but this one, who's never relapsed, neither of them have, this one, the antibody is not functional. It will not activate complement. So you have to do a functional assay, not just an assay for the antibody. In fact, these antibodies can be protective rather than pathologic, and they block attack from other functional antibodies. So, and this occurred with switch in the IgG class, but it was still an aquaporin 4 antibody. So it's very important to do the functional assay for astrocyte killing as well as the antibody. CIDP, well, you know, what is the immunology of CIDP? What's the antibodies? Kind of vague. More recently, there's nodal types of CIDP where they've found antibodies that are directed here to neurofacin, to Casper, and to contactin. These are all adhesion molecules, and the antibodies destroy the adhesion of the myelin to the axon underneath, and so it starts opening up the myelin and you get CIDP. It's only a minority of patients that have this, but it's only recently that they've identified these antibodies, and these tend to be bad actors not responding to standard therapy. In any event, we reported our results on transplant in Journal of Neurology in 2020, 60 patients, which was actually 66, and that's more than even the big ICE study on IVIG in neurology that made IVIG standard of care. But in any event, again, we use plasmapheresis, for people failing plasmapheresis and IVIG, which are the only really treatments that randomized trials showed effective. We use plasmapheresis, Cytoxin ATG, rituximab, and these were refractory patients. You can see for every year out to 5 years, 80% stayed in remission. Importantly, if we looked at their disability, you can see before transplant, we had bedbound people, people here in a wheelchair, people using walkers, people using canes or crutches, AFOs, and the blue is normal. And you can see how it flips after transplant, the marked improvement. You know, you can argue that the AFO went up a little bit. In fact, the neurology reviewer argued that, but the reason they did is as you got off of a wheelchair or a walker, you would go to AFOs and then eventually get off of that. So marked improvement, multiple parameters, and of course, in quality of life. And these are all drug-free in the remission. I don't have much time to continue, but in Scleroderma, there have been 3 randomized trials. I did one, the Europeans, and another group in America. The neutropenia is about 10 days in those trials, and Scleroderma affects the heart, and if the heart has compromised, they might die during the transplant. So for these really bad hearts, we started a CAST regimen, cardiac safe transplant, and it worked. It worked so well, we started doing it for everybody. There's only 5 days of neutropenia, and if you can get your neutropenia to 5 days, it's a godsend. And in fact, it made the hardest transplant the easiest. This is the regimen. It's in our publication, which is in Bone Marrow Transplant. Fludarabine, only 1 dose of Cytoxin, rituximab, unselected graft. Worked very well. Now, we don't have that long 10-year follow-up or 5-year, but at least within the first 3 years, it's been highly effective and very, very safe. And still to this day, rheumatologists are concerned not about the efficacy, but the safety of the procedure, which I understand. This is a super safe regimen. And then Crohn's disease, we used to do autologous, but pretty much everybody would relapse. I mean, you know, they'd go 3 years, 50% relapse by 5 years, almost everybody did. And that was very disheartening for me. So I tried an allogeneic protocol, and we did, my thought was we'd have to get engraftment, and we used this regimen of fludarabine, cyclophosphamide, alemtuzumab, and of course 6 months of Prograft to prevent graft versus host disease and also to ensure engraftment. It turned out nobody engrafted, and so we did dose escalation. And at the highest dose, we had a mortality due to a virus. So I just stopped it, and I continued to follow them. I published 5-year follow-up here. But in fact, we've recontacted, and everyone is now 10 years out, and they are still in complete remission on no medications whatsoever. And by complete remission, I mean they're drug-free, they're clinical remission, no symptoms, no diarrhea, no CT evidence disease, no endoscopic disease, and histologic remissions. This is what we've always wanted, and that was achieved. And again, you'll just have to go to the paper for that. So in summary, we really do have, the publications are out to 5 years, but I'm writing a new material and I've been contacting patients. We're getting 10-year follow-up. We have people with MS out 20 years, 10 to 20 years, still in remission, no evidence of new disease, no relapses, no medications. But remember for MS, no inflammation, no response. If it's not relapsing, remitting, I wouldn't do it. Keep treatment risk low for this disease because they have significant morbidity, but not really death related to it. So non-myeloablative regimens, this is the one I use, Cytoxan ATG, rituximab is a good substitute. Neuromyelitis optica, we use a different regimen. Good biological marker for disease activity, which is unusual in autoimmune diseases, and it disappeared in the majority of our patients. Check for functionality, not just the antibody. CIDP, I won't go into why we ask, is it CIDP? The majority of people referred to us did not have CIDP, including a prestigious center in Europe where the patient sent to us for CIDP on IVIG actually had B12 deficiency. We missed the diagnosis too at times. So in any event, this was the regimen. It's highly effective in these refractory cases, cost effective. We published that with Basel. We also published in MS the cost effectiveness. Systemic sclerosis, it is a matter of the heart to get through transplant. And the regimen we found with 5 days of neutropenia to be the safest is this one, short-term 3-year follow-up, just as good as the more intense non-myeloablative or the intense TBI myeloablative regimen of the Scott trial. Crohn's, we used cord blood, a different regimen at the highest dose escalation. We never got engraftment, but we had an atypical viral infection, adenovirus. We stopped, continued to watch. And even at the lowest doses, they have all remained in remission for 10 years. We reported to 5 years, but they're out to 10 years. And I just want to follow up. This is the medical textbook that's been published, and every person who's a part of this meeting presenting today have contributed to it, and I want to thank you for that. And I have another textbook, not textbook, a lay book that I was asked to do by Simon & Schuster out of New York. It will be in bookstores, in airports, regular bookstores, buy it on Amazon. It will be out this year. It's actually written. I just have to do some artwork for it and also proof what was written and get it to their editor to start their editing process. I never have in the past used the cure. I put it here for the lay with a caveat on the introduction. But we now have people with multiple sclerosis. Everybody I've talked to so far, 20 years out, no relapses, no progression. We have people with scleroderma 15 years out, same thing. So, and I just showed you that, again, 10-year data on our neuromyelitis optica and on our Crohn's disease and CIDP is we're getting people out 10 years now without ever restarting therapy and no new symptoms. So I am, for the first time, starting to say that. Maybe they'll still relapse after 20 years, but at least it's totally changed the natural history of the disease. I want to thank everyone for this opportunity.